I'm going to talk today a little bit about what are the complications that we need to know about with IVC filters. And some of these complications have been brought up by previous speakers. Those are my disclosures. So this is what I like to tell patients. IVC filters are like credit cards. They can be your best friend, or they can be your worst enemy. IVC filter insertion has been declining over the past several years, but in the early 2000s, it really hit an all-time high. And then once we started to see the complications with filters, especially the retrievable filters, then everyone kind of got scared. And as we see all these legal commercials, a lot of people started to get these filters out, and the number of filters being put in has declined. But when you look at the retrieval rate of IVC filters, it's still pretty dismal. And when you look at the studies that have been done, it ranges anywhere from about 4% to about 40%. Now, I can tell you, at Penn, every single filter in IR that we put in is tracked in a database, and we're very closely monitoring these patients and bringing them back in 3 months, and we're sending them letters and doing whatever we can to get these patients back. But even with that, our retrieval rate is 45%. You have patients who are lost to follow-up, especially trauma patients. So there's a lot of different factors that go with that. Well, what are the complications that we know with IVC filters? They can fracture, migrate, tilt, recurrent DVT, PE, caval thrombosis, which can occur in up to 25% of cases, and then vascular injury or perforation. And that perforation could be into the aorta, the bowel, abutting the spine. There's a whole variety, which I'm sure all of you have seen. I'm just going to show a few examples of complications that you're more likely to see. The tip-embedded filter. This is very, very common. We see this all the time. And here's a filter abutting the caval wall, and we do rotational venography, and that tells us sort of the orientation of where that tip is. A fracture with an embolized fragment. Now, I can tell you, when you're taking these filters out, you really want to get good plain radiographs of the filter. You want to know what the filter looks like before you take these filters out. So here is a filter that is tilted, and it's actually fragmented, and we can see a leg is actually in the heart, and it actually had been there for quite a while. So fragments can not only be sort of local, right around the filter, but they can go to other parts of the body. Now, we always sort of think that, are all these complications really limited to retrievable filters? Well, not at all. We can have complications with permanent filters as well. Here is a fractured Greenfield filter. It's sort of hard to see here. I don't know how well it's showing up. This is an interesting case of a filter causing a pseudoaneurysm. And this patient presented with bleeding, and we actually had to go in and coil embolize this vessel. This is one of my favorite cases, and we'll blame this one on the fellow. But here is a Venotech filter misplacement. This is the filter being put in from the jugular. You can see we have our catheter here. We're doing our venogram. Everything looks good. But when we do our exchange, you always want to make sure that your wire is all the way down the cava. If your wire comes back, make sure you advance it and reconfirm you're in the cava. Because when we put that filter in, I don't know how well you can see that, but there is a filter placed in the gonadal vein. Now, I actually had a similar case where we were actually deploying this from the groin and used an Amplatz wire and actually dissected the caval wall and implanted a filter within the caval wall. And then once we did cone beam CT, we could see that it was within the caval wall, and we actually put a big stent, caval stent, to barricade it. It was an 85-year-old patient, and then we put another filter within the cava. And there's our second filter placed in the actual real IVC. This is an interesting case of a gentleman who actually at an outside hospital was undergoing cardiac surgery and had calf DVT. And he was towards the end of his course of anticoagulation. But because he hadn't completed that therapy yet, they said, you're going for cardiac surgery, we want to put a filter in. So they put a filter in. And the best filter that they can put in was a trapeze. So just 4 or 5 days after getting the trapeze, the patient's legs started to swell. And he actually said to the cardiac surgeon on Monday morning, in pre-op, my legs are swollen. And the answer was, well, you know what? You've got some right-sided heart failure, which is why we're going to be doing the cardiac surgery here. Your heart function will improve. Don't worry about it. And then afterwards, in recovery, over the next few days, his legs got bigger and bigger, and then they scanned him, found that he had acute IVC thrombosis, and then he got transferred to Penn, but he was like 3 days post-cardiac surgery. So we had to wait quite a while. So the second picture here is at his 6-month follow-up when I finally got clearance from cardiac surgery. And he ultimately ended up doing fine because we reconstructed the cava and crushed the filter. So the take-home points: exercise good judgment in placing filters. This is also your opportunity to educate other physicians, because other physicians will be calling you to place a filter. And if you are asked to place a filter for a sort of relative indication, this is your opportunity as the experts to say, no, this is why we feel a filter should not be placed. You need to maximize anticoagulation. And until a patient has failed therapeutic anticoagulation, and the key word here is therapeutic anticoagulation, you cannot say that anticoagulation has failed. And finally, as Daniela mentioned, we want to get these filters out when they're no longer needed.